probably spoke at about 25 of these symposia, so I think he had a pretty good history here, and he passed away in March, was appropriately buried on April Fool's Day. And Rick was a native Iowan. He always talked about how he attended Grinnell College medical school and residency. We're at University of Iowa in Iowa City. He did 2 fellowships, one with Kroll Beard in San Francisco, who was not the first oculoplastic surgeon, but he sort of wrote the first comprehensive text on ptosis surgery, which is a very important topic. My subspecialty may only exist because of this. And he also spent 6 months with Orkin Stasier in Albany, and Orkin was a consummate anatomist and really a smart guy, and I think Rick should have given him more credit. Kroll died a couple decades ago. Orkin died in 2020, and again Rick this year. But he spent a lot of years at Iowa. The top images from a University of Iowa faculty summer party, which apparently happened yearly at Stan Thompson's farm. Stan was a neuro-ophthalmologist who passed away in his 90s early this year, and I actually went to a memorial for Stan this spring and took a photo at the farm. Keith Carter, who is one of Rick's grand fellows and is the chair at Iowa, is in the center of that. The little lady standing next to him is my wife, who is a part-time neuro-ophthalmologist at Iowa, of all places. But Rick Anderson published over 300 peer-reviewed publications, some very fundamental stuff in our field, but importantly for this group, his paper, Anatomic Approach to Blepharospasm, written with Bill Gillum, who moved to West Texas and didn't really do full-time plastic afterward. And he also was one of the early folks treating people with botulinum toxin, which helped me because I was with Rick from 87 to 89 in Salt Lake City, and we were doing a lot of Botox treatment, but we were still doing a lot of myectomy surgery, because what's now Botox was investigational, and we had Rick actually didn't think it would ever get FDA approved because of the orphan disease status and so on. Obviously, it's turned into kind of a big thing. But the top image there is the Aesopris tree from a few years ago. It needs to be filled out a little bit more because it's about 3 or 4 years old now, and a number of people have trained in the meantime. But he had a very fundamental impact. This was the bottom images, his fellows who went to his funeral. But that whole section of the tree is people that Rick trained or were trained by someone who trained him, and I think he probably has great grand fellows now, so grand fellows who have trained fellows. And I think his trainees also had probably a special impact for people sitting in the audience, because I think they're a real resource for blepharospasm patients. I don't think people outside of this tree, too many of them, have gotten really good at doing the surgery, and this was a couple of years ago when we did a dinner for him at Academy. So anyway, treatment of blepharospasm, I'm going to sort of wander off topic in a couple of ways, but there are these supportive things like this woman who wore goggles, which, and in years past at this meeting, it seems like I always had folks wearing goggles and so on and so forth. Peter's got his hat, so good for him. I see a few hats out in the audience, and I'm sure you're not preparing for rain here or sunshine. This is helping your spasm. Systemic medications can help. Now, this is lorazepam. Some of you may recognize this, but which frankly in our survey done 30 years ago was the most frequent medication that people reported as helping, with the bottom line being that with rare exceptions, none of these meds do great. I don't know what Dr. Hyatt and Norris and other speakers' experience is, but I can count on a couple of fingers of one hand all the blepharospasm patients I've ever had or interacted with who've done so well with some oral medication that they did not need other treatment. Now, Botox, and I'm using the word Botox generically. Botox is a little bit like Kleenex now. I think there are now 5 botulinum A neurotoxins in use. Botulinum B has sort of faded into obscurity, as it probably should have. And you'll notice this slide says oculinum, and it's 200 units per vial, but it also expired back in September of 1988. So, back then you could get 200 units investigationally for $20. So it was a little bit cheaper in that era, and I think Allergan may have made the deal of the century when they bought rights to it back in 1990. Myectomy surgery, I think, is still relevant, although less relevant than before. I think it's really a specialty item for special patients. Neurectomy surgery is not done much anymore, although there are a few places that employ it or use that sort of in addition to myectomy surgery, and I think maybe they know something I don't know, but it's not bad. I had a patient who went up to Canada to meet with Dr. Farias, and maybe some folks out there have done that, but I think biofeedback yoga, there's a nice handout in your bag that you can read on this, which probably may tell you more than I know about it. Now this scheme we devised, I think Jamie Patronelli and I devised this in 1990 when we had a course with Rick that was the first course really at any medical meeting on how to deliver treatment for blepharospasm. And for better or worse, we don't have deep brain stimulation in here, etc. The word neurectomy you could probably excise, but this basic scheme kind of remains somewhat valid today. So in that regard, you can argue how much progress we've made since 1990. The foundation, I think, has done a great job. This is Maddie Lou Coster in her younger days in Beaumont. She was always kind of on the move. Mr. Coster kind of faded into obscurity after some time. And I don't know, there are many folks in the audience who came to this meeting back when Maddie Lou was running it, or because Mary Lou, her daughter, who was kind of a spitting image of Maddie Lou, except she did not have blepharospasm, but she ran it for many years, and I think the foundation is very lucky to have found Charlene, who has done a great job keeping this alive, because I sort of wondered where the foundation would end up. And I spoke to a younger researcher who was interested in things. This is from a survey that we published in '98, but the survey was actually executed, I think, in 1989. And I think the number of doctors the average patient sees to get diagnosis has dropped slightly, probably by about 1, because the average was about 4.2 or 4.3 in the study. So in 30 years we've gotten to where patients maybe see 1 or 2 fewer doctors. The ophthalmologists still kind of lead the charge in terms of making diagnosis, but and I think this probably all deserves study again. Now, myectomy was, as a surgical treatment, and neurectomy both preceded the use of neurotoxins. So we got neurectomy surgery, and actually it goes back way before Callahan and Reynolds to the 1940s, attempts at selective avulsion. Peter, if you turn around, Dr. Couch is right behind you. And Stephen, if you check in with the man with the hat here, he's going to need to get your talk loaded when the time comes. Selective avulsion. Now, one problem with neurectomy is that the facial nerve branches do tend to overlap. So, and there is reinnervation in that if you, and people do try to strip out whole sections of nerves, but it is difficult to get lasting effect. And so reoperation is an issue. Recurrence is a very significant issue, or you can get, if you're aggressive, you can get patients like the chap top right, who's got paralytic ectropion and some facial paralysis, and the other patient who who has ptosis on the left, but has to use a finger to open the right eye, common trick for blepharospasm patients. So anyway, there are all kinds of bad side effects with neurectomy. I think Rick may have overstated them slightly, but still the number of reoperations from other studies, not his papers, 4.5 times as frequent. I think that was from the Mayo paper. So there were early descriptions of limited muscle stripping. Dr. Norris had a much nicer slide than I did because mine ends in 1986, so you can tell you how busy I've been in updating this. But it shows he used a slide for just all dystonia. This is for blepharospasm, but you can still see until about 1976, 77, the number of papers was really minuscule, so it was kind of dying in a sea of disinterest. And Henderson, who was at Mayo Clinic, actually described a, quote, muscle stripping operation, end quote, in 1956, but it had limited duration of effect, and he didn't do very many cases, probably because it wasn't working very well. It was kind of a blepharoplasty plus, and unfortunately, that's what most people think of a myectomy as, which is why most doctors, who I think don't have proper training in it, try to perform the procedure based on what they know, and they just, their imagination just doesn't allow them to do what needs to be done to make the operation work. Now, Gillum and Anderson published this in Archives in 1981 with much more extensive excision, and it's kind of a commentary on Rick's personality that he was willing to sort of go full force on this, because you literally had to strip out almost every single muscle fiber you can find in the eyelids to make this operation work for essential blepharospasm. Dr. Gabriela Espinosa nicely reviewed the muscles. Corrugator procerus muscle is this midline strip with the corrugators angling outward, but all of these protractors help pull the eyes closed, and the corrugator procerus and orbicularis muscle are probably the key protractors in terms of blepharospasm. And so surgical treatment, you have to do quite extensive surgery. Botox, I think you can predictably treat this, but I think the anatomic knowledge that you gain from surgery is really, really helpful. And I'm going to use a couple of different terms, and these are just what I'm using, and we can find alternate terms out there, and in the end, we're probably at some level talking about the same thing, but the myectomies that I did with Anderson back in the 80s, when Botox was not available predictably as a treatment option, I would call it radical myectomy. And our goal here, it was a eyelid and brow incision typically, and our goal was to treat the spasm effectively enough that with no additional treatment, the patient was visually functional. And it's a really hard operation. It's really extensive. I'm going to show you a couple of patients which weren't necessarily typical, but we had a lot of these sort of results. And what I would call limited myectomy, which now is probably a myectomy because it's anticipated that in essentially all of these patients we're going to continue to treat with a botulinum toxin postoperatively. With insurance, you never want to use the word limited because then you get limited payment, and because there's no CPT code for this, getting paid at all has been a huge challenge and is really a barrier to patients as well, because doctors don't like to do extremely involved, extensive operations that involve a lot of surgery and a lot of care that they get paid nothing for. And Dr. Mamari is going to talk a good bit about these associated malpositions, and certainly ptosis. If you're squeezing your eyes shut and you're co-contracting and trying to open, you probably tear the levator aponeurosis tendon, which tends to thin and retract a bit with age anyway. You're going to tear that more. You probably tear the lateral canthal tendon more. You may get more dermatochalasis. So the muscle that you take out is quite extensive. That is not a piece of steak on the photo there. That is the muscle that came out of the brow, eyelid, lateral canthus of this patient. And we usually don't have to do this anymore. And these are typical sore patients. I can still remember both these chaps' names, but you can see they had, and in both these cases, they actually had or the gentleman on the right had a lower myectomy as well, which left him with a little bit of lid retraction. And certainly doesn't help his looks, but he was functional and pretty happy because he could see again, and he couldn't see before. And sorry to gross people out if they're not into surgical photos, I kind of like them. But this shows how much tissue you would cut out. So in this so-called radical myectomy, we went all the way around the lateral canthus and actually into the lateral lower lid. And that's one block of muscle that was cut out in one piece. And most of these patients had a lot of numbness, and they had tremendous swelling that went on for months postoperatively. So, and the first thing you told everybody is this is not cosmetic surgery. So you did this very broad excision. You can see at the end, we've left the superficial vascular arcade and deep vascular arcade intact, but we've stripped essentially every visible muscle fiber out. And we would patch these patients postoperatively. And so this case is done under general anesthetic. You can see an endotracheal tube that hasn't been removed yet. So the course, a lot of edema. We would always tell people at least 6 months, a lot of foreheading anesthesia. We were not too respectful of the nerves because we were after muscle. And you had these secondary things to treat. Now I mentioned botulinum toxin. So Botox changed the scene in terms of surgery on patients completely, because probably 90-some%, 95% of patients, Botox is their final best treatment in the end. Or let's say a botulinum toxin. Again, I'm using the Kleenex version of botulinum toxin, Botox. But there is a subset of patients that don't do well. They don't get a great result. They tell me they're only good for really 2 weeks. They can't really go more than 8 weeks between treatments. Again, insurance doesn't like that, which is not necessarily a specific reason to do surgery, but doing a debulking of the periorbital orbicularis, especially upper lid, is really a good thing. And in most of these patients, I will take part of the corrugator, but I don't go as aggressively because I don't want to get both the bleeding and the numbness and such that patients had permanently after radical myectomy. So one thing you don't want to do, though, is have your doctor do like an aggressive blepharoplasty on you and then decide, oh, that didn't work because the spasm came back in 2 months, and send you on because they've cut out all this skin that we need postoperatively to allow your eyes to close. So, and it really makes the operation much more difficult. So my advice to you as patients would be, if you really think you need a myectomy, find the right doctor to do it and do that from the get-go. Don't let your general ophthalmologist or facial plastic or general plastic surgeon do a more routine, almost cosmetic blepharoplasty on you and then send you on. But this is, in terms of swelling and so forth, a little more consistent with what might be kind of an aggressive blepharoplasty, if you will. Now, about 8 years ago, my fellow and a resident and I looked at upper myectomy and what effect it had on treatment interval, because my feeling was, and we didn't really use a good survey instrument, which would have made this a more powerful study, but we just looked at dose and treatment interval, and the treatment interval did increase in the patients. It was 10.1 weeks pre-limited myectomy, or we'll just call it myectomy now, and 15.7 weeks, which is an acceptable interval. And I'd say, just if you looked at all the charts, the symptomatic relief was tremendous. So this sort of operation is suitable for patients who get a poor functional result or poor duration of effect with Botox. And it does allow you to concurrently treat all of these other things that Dr. Mamari is going to teach us about in a bit after lunch. And healing issues, yeah, you have a lot more swelling than you have with a cosmetic blepharoplasty. I don't tell people in 2 weeks you can go out with friends and nobody will notice. But having said that, it's not the chronic lymphedema that you saw in those patients. But they do have to expect to continue botulinum toxin therapy. Okay, I do not own any Allergan or AbbVie stock. I actually, to your point, Dr. Norris, I do own Revant stock, and they do now have a neurotoxin Daxxify, which is not FDA approved. But, you know, we talk about the drugs. any of the botulinum A's you can use effectively for blepharospasm. It's just some of them your insurance isn't going to pay for it. So there's a patient a month after a so-called, quote, limited myectomy, and she's smiling, which is good, so she appears to be happy. So less extensive muscle, cosmetically acceptable result, and convert a patient who does poorly with botulinum therapy into someone who does well. Now, I'm going to touch on chemomyectomy for a couple reasons. One is I actually have the slides. Andy Harrison gave some of this information to me some years ago. Morris Hartstein, who was at St. Louis U, after I went into private practice for a couple of years, he was at St. Louis U. He actually was an investigator in the Doxil study, which I don't believe ever got published. But Jonathan Wirtschafter, who was at University of Minnesota, this shows him with a young and alive Matty Lou. He had this concept in studies, and Linda McLoone, who was a researcher there, helped him with this. Initially, they did primate studies and then went on and did human studies, which I guess is the way you're supposed to do these things. But anyway, they used doxorubicin and Doxil. Doxorubicin is adriamycin, so it's a cancer chemotherapy drug. It actually is well known for causing cardiac damage when you treat systemically with it. I think the doses that were used in these studies are way, way below the doses that would cause cardiac side effects. So doxorubicin, they published this in a couple of forums, but 22 patients, and they had long-term follow-up. The patients said they would repeat it. You can get skin ulceration, swelling, they can get scarring, so they can actually kind of look like, you know, a really beat-up myectomy patient after these treatments. So Wirtschafter had the idea of using Doxil, which is a liposomal encapsulated doxorubicin formulation. It does allow it to spread a little more. I think it's kind of a little more gradual onset. Patients had 8 injections over a year. You can see a patient after an early injection, how you get this just tremendous eyelid erythema that goes on for weeks. And in some patients, that was a reason to cease therapy. 13 patients enrolled. As I said, I don't think this data ever got published. One patient had a myectomy after the trial, and it's interesting the effects of both doxorubicin and Doxil. I mean, was anybody out here involved in those studies? Matty Lou Koster was actually the first person injected with doxorubicin. So I think if we had said that we're going to do brain surgery for it, experimental brain surgery, she would have been the first person to volunteer for this. But 2 patients extended treatment more than a month, 2 more than 2 months. Remember, there are only 13 patients, 1 more than 5 months, and 1 patient went over 18 months before requesting Botox, which is very interesting. And talking to Andy Harrison, who's still at University of Minnesota and knew Jonathan Wirtschafter, I mean, probably, you know, he and I are some of the few people that are actually aware of what went on with all this back then, who are still practicing medicine. He thinks there's actually something there, and it just kind of ran out of steam and money, and there's not a lot of commercial interest in this. But remember, Botox, there was no commercial interest in it until Allergan bought it. They bought the 18-month worldwide drug supply, the rights for 17 years, the whole caboodle for like $20-some million. So, which, I don't know, they made a few $1 billion off of that before they had to produce any more drug. So and this goes back to our survey done many years ago, which I think it would be well advised to repeat some of this, but when we asked patient, would you recommend this to others? Okay, 95%, very high acceptance for botulinum. Now, you had to have the treatment to be able to recommend it. So myectomy surgery, 80%. So 20% of the people wouldn't do it again. Oral medications, only a little over half of people thought they were worth their while. It is really interesting, though, if you took patients from this survey who'd had botulinum toxin, they'd had oral medication therapy, they'd had myectomy surgery, and said, what's your first, second, and third most effective treatment? Okay, the patients who had myectomy, 57% of them said it did more for them than any other treatment, which is, I think, pretty fascinating. Now, in that era, most of those people had the so-called radical myectomy, so they had the big-time surgery. And this survey got, as I said, it didn't get published until over 10 years after it was taken, but the Essential Blepharospasm Foundation helped with it. They're the ones who distributed the survey back then. I think in terms of Blepharospasm Foundation, they were patients, they were in contact with more folks than the Dystonia Foundation or any of the other groups. We got 1,653 patients to respond. A very high number of the patients were happy with what the Blepharospasm Foundation had done to help them. The myectomy patients, 88% said they were improved, 86% for botulinum atoxin. Again, that was sort of early in the therapeutic scheme, but very high patient acceptance. And I think, as I said, I think Rick Anderson wrote this because this is actually published as the abstract. He credited Matty Lou Koster and the Blepharospasm Foundation by name. I'd say much of this kind of remains very relevant today. Now, treatment horizons, we can always try to improve surgical therapy. We can, Steve Couch is going to talk to us about toxins and the different toxins, which I think is an interesting topic, and I think we as clinicians and patients have more to learn there. I think there are some little gems possibly hiding. Chemo destruction, I think, may warrant revisiting, so some of us who have time should probably figure out how to make that work. Centrally acting drugs, I always keep looking for something that is a incredible mousetrap, and nothing has shown up in the 35 years I've been dealing with this. Deep brain stimulation, I need to learn more about, and is there some kind of magic bullet out there? I don't know the answer, but I want to thank everybody, and while we're getting Steve Couch teed up for this, perhaps I can take a couple of questions.
I have TN also. The myectomy, you do mostly muscles, but you also said you don't really pay attention to nerves. Are you doing it with the tri-nerves, 5 through 7? Because that affects the TN, trigeminal neuralgia.
Okay, so the question is trigeminal neuralgia and nerves, and what do we do surgically in regard to that? And trigeminal neuralgia overlapping with blepharospasm, I think, is a very difficult topic, and I don't think I could even give a highly intelligent talk on that one. I will tell you that the nerves, when you do a myectomy surgery, some people do refer to it as a neuromyectomy because we're cutting out muscle. And Rick Anderson's original thought on that was sound, in that muscle fibers do not grow back. They are not going to regenerate. You're not growing new muscle fibers as an adult. Nerves can regenerate and re-innervate over time. But when you do this surgery, especially, not only are we taking upper lid, brow protractor muscle out, but you're wrapping around laterally, all the way around the eyelid laterally. So you're removing a lot of the motor.
I need to copy that.
You are also removing the terminal sensory nerves. Now, these are not the nerves that are causing you pain in trigeminal neuralgia.
We're not going to use it,
now,
but it's going to
could
be used
surgery set off trigeminal neuralgia? I'd have to say yes, because you're tweaking these nerves. And as you know, any superficial stimulus can sometimes set off trigeminal neuralgia. So I don't know if that really answers your question, but that's, yeah, that may be the most intelligent answer I can give on that one. So, and all right, one more question.
Okay, so do you have a view? You said that the medications don't really work, but I've also heard like the clonazepam, etc., can cause long-term dementia. Do you have any view on that statement?
I do not know chronic long-term effects. I think maybe one of the neurologists here could give you a great answer to that in the Q&A later, so we'll hang on to that one. Now, Dr. Couch did give me a shout out because he is a big Ritalin fan. Every patient I try to put on it seems to have cardiac disease or something, and their internist says absolutely not. I think especially in the management of apraxia, which is another whole topic that we haven't really hit on too heavily. But we can ask him the Ritalin question later. But Dr. Couch is sort of a great colleague in town. He's a professor at WashU. I notice he doesn't have to put any adjectives in front of it, so that's a big thing now. He's kind of a big thing. But he's gonna talk to us about trying to make sense of all the neurotoxins. Yeah, I like the new logo on it.